Hey all, Eric Christensen from the Real Life Pharmacology podcast. I am a big podcast listener. I like learning different things and just stumbled across a podcast that fits right in my wheelhouse, and I'm guessing it'll fit in yours as well. You got to check out the Mechanism of Action podcast. It reviews a lot of history about where medications came from and were derived. It's really going to help your understanding of medications and also be a little bit entertaining as well. So go check that out. Highly recommend it. Mechanism of Action podcast. Hey all, welcome back to the Real Life Pharmacology podcast. On today's episode, I'm going to cover agents that treat gastroparesis or help with the symptoms. These are oftentimes called pro-motility agents. The two that I'm going to cover the most are metoclopramide as well as erythromycin. So first, just a little bit of background about what gastroparesis is. Maybe you're not terribly familiar with it, but essentially it's delayed gastric emptying. And it's considered to be without mechanical obstruction. And essentially the muscles and the nerves fail to move food into the small intestine at a normal rate. It's at a slower or reduced rate. And this can lead to patient symptoms, as you could expect. So kind of that backing up of food without the motility or with low motility. You can have some nausea, vomiting, postprandial fullness or excessive fullness type feeling, bloating, abdominal discomfort, maybe even getting close to the realm of being painful. In severe cases, you can have weight loss as well. So this delayed gastric emptying can affect medication, so I think it's important to remember that. It can also cause some variability in disease states like diabetes. So, again, pay attention to that. It's important to understand gastroparesis and how it works for sure. Now, the most common cause, a little bit more background, most common cause is diabetes. That is absolutely what I see in practice. Chronic hyperglycemia can essentially damage the nerves that are associated with the gut and impair their action. And impair gastric muscle contractions as well. So, from a pharmacist, medical, nursing side, getting glucose control, good glucose control is really, really important with diabetic gastroparesis. There are other causes. I'm not going to get into that a ton. You can have surgical complications. You can have neurological disorders like Parkinson's. That's probably another common one that I see, or potentially stroke. So again, there's numerous causes here. That's not generally what this podcast is about. So I am going to start getting into some of the medications that can first worsen gastroparesis. So really important to pay attention to these medications when a patient is diagnosed with gastroparesis and is having significant symptoms. Opioids slow down the gut. Really got to pay attention to them. Your morphine, oxycodone, hydrocodone, so on and so forth. They reduce that gastrointestinal motility through opioid receptor activation. The other classes of medications, GLP-1 agonists, that's what they do. They promote fullness. They kind of slow down the gut, intentionally slow that gastric emptying and promote fullness for patients so they don't eat as much and they can lose weight and help control their blood sugars with these medications. So, semaglutide, tirzepatide, liraglutide, these are all medications that can, GLP-1 agonists that can mimic gastroparesis or worsen gastroparesis. So again, pay attention to that if that's the right fit for your patient. And then the last medication class, this is a huge class, covers a broad range of agents, but any medication with anticholinergic action can worsen gastroparesis. Oxybutynin, benztropine, diphenhydramine, scopolamine, We've got tricyclic antidepressants like amitriptyline and nortriptyline. These essentially slow down or reduce GI smooth muscle contractions, and so that could certainly worsen the symptoms of gastroparesis. All right, now to the good part. Let's talk about some of the medications that can help treat or improve the symptoms of gastroparesis. Metoclopramide is the number one medication I see utilized for gastroparesis, the most common one I see. Mechanistically, this is a dopamine 2 antagonist, and it can increase acetylcholine release. So if you remember that anticholinergics block acetylcholine and make gastroparesis worse, increasing acetylcholine action or release can potentially help the symptoms of gastroparesis. Metoclopramide also has antiemetic effects as well. So if a patient's struggling with nausea associated with their gastroparesis, this medication makes a lot of sense. Dosing frequency can be a challenge for some patients. Usually we give it about 30 minutes before meals and at bedtime. 3 to 4 times a day is when you see this medication dose. So again, having to give it that often, can be a little bit of a nuisance sometimes for some patients. We do like to try to limit the use, 8 weeks, 12 weeks or less if possible, because of that dopamine blocking action. We can cause movement type disorders and movement type adverse effects. We can cause tardive dyskinesia. We can cause drug-induced Parkinson's type syndrome. We can cause dystonia. So basically all the things that can happen with antipsychotics can happen with metoclopramide. So that is super, super important to pay attention to. Probably more so important in older adults who are at risk for falls. Also those with Parkinson's disease or pre-existing movement type disorders. Metoclopramide can certainly worsen that. So again, medications used for gastroparesis in general, definitely good to reassess them periodically and make sure that we don't need them long term. And coupled with that, going back to the medication list and saying, hey, are they on meds that's worsening their gastroparesis? Can we get rid of them, reduce them, change them before we actually add a medication to treat or manage gastroparesis? So again, paying attention to that stuff, really, really important as a geriatric pharmacist for sure. The other medication that I do see periodically is erythromycin. Now, erythromycin is a macrolide antibiotic. Its action in improving gastric motility, it actually stimulates or agonizes motilin receptors, which can help in that peristalsis action of movement of the gut and produce strong gastric muscle contractions. So erythromycin versus metoclopramide. So one of the advantages of erythromycin is it generally tends to work pretty quickly. And the setting you're probably more likely to see it used in is in acute care type situations, like a hospitalized patient or somebody with a pretty severe acute exacerbation. One of the challenges with erythromycin in the management of gastroparesis is tachyphylaxis can develop. The way I remember this when it relates to medications, it's basically a sudden decrease in effectiveness. So if you remember what the term tolerance is, it's basically that, but essentially a little bit quicker. So it can lose effectiveness, its ability to work within weeks to even days at some times for erythromycin, and so that can be a challenge in using this medication, and that it's generally not going to be a long-term solution for gastroparesis management. The other big challenge with erythromycin is it has a ton of drug interactions, and it's got drug interactions via CYP3A4. So many medications are metabolized by CYP3A4, apixaban, rivaroxaban, many of the statins, simvastatin probably being one of the worst ones by CYP3A4 inhibition drug interactions, carbamazepine, warfarin, even medications like trazodone and tadalafil. Now, a lot of these medications are just kind of monitor, but there are definitely some contraindications as well. And honestly, when I see erythromycin being utilized, I may recognize some of the drugs that are CYP3A4 mediated, but I generally do a drug interaction screen just to be safe, just to make sure I'm not missing anything, because there are so many. So I would encourage you to do that as well when you see a prescription for erythromycin in a patient. The other important drug interaction to pay attention to with erythromycin is QT prolongation. Antipsychotics, amiodarone, these can all be problematic when used together with erythromycin, increasing that QT interval, and obviously potentially increasing the risk for cardiac arrhythmias and complications. Now, alternatively, azithromycin, there is some evidence to show that it can be beneficial. It's generally got a longer half-life, so it's easier to dose, or we don't have to dose it as frequently as erythromycin, so that's a little bit of an advantage. But I would say, the evidence is a little bit more limited compared to erythromycin in the setting of gastroparesis. For you outside the United States, domperidone, this medication is not approved in the United States. I do work somewhat close to the border here in the northern U.S. I have not seen this medication personally, but I do know that QTc prolongation and risk for ventricular arrhythmias is an important thing to remember with that medication. Again, I don't see it utilized in the United States here, but for those of you outside the United States, that's always a good test prep nugget to remember with that medication. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, do a huge favor, leave a rating review on iTunes or wherever you're listening. Share us with friends, colleagues, listservs, anybody you think could benefit from some pharmacology education. And of course, support the sponsor, med101.com/store. We've got tons of study materials there that can help you prepare for and pass your exam. We've helped over 10,000 candidates at this point over the years, and we can absolutely help you too. So I'm greatly appreciative of your support there. Helps keep this podcast financially viable, of course. All right. Thanks so much for listening. If you've got any comments, suggestions, mededucation101@gmail.com. Take care. Hope you have a great rest of your day.